Hello everyone, my name is Chris Slater. I'm a dietitian working at Salford Royal. So I work in the weight management service and also the bariatric team as well. I've worked there for quite a few years, and I know you last month you had a bit of a chat from Professor Sanapati, who talked through the different surgery options, but I'm aware that not everybody that's on the call today will have attended that one. So aim for today really is just to go through a bit of a brief overview of the different types of surgeries, and then we'll go into the dietary changes that you're going to need to make before and after surgery, and then we'll give you some a chance to ask some questions as well as we go along. Or if that's okay, we'll get going. All of our operations are done laparoscopically, so it's all keyhole surgery. It's not open as much as possible, so it's all laparoscopic. So that means that 5 small incisions are made across your abdomen, and then they insert the first instrument, which is to blow you up full of gas. So they separate all the organs out. It's not a gory process, so they can see what they're doing basically. The next instrument that they insert is a camera. So they can see what they're doing, and then they put the rest of the instruments in, and then they do the operation like they're playing a computer game. So they just start looking at a screen, playing the Xbox, basically. It's quite a quick operation as far as operations go, anywhere between 45 minutes for a gastric band to maybe 2 hours for a bypass, maybe a little bit longer if the surgery is a bit more challenging, but generally, yeah, so around about that time. First thing to note is that they do put you to sleep completely. It's general anaesthetic, it's not local, so you can't ask for a local anaesthetic and be awake. It's general anaesthetic, they put you to sleep. So once they've done the operation, they do a dye test. So they put a dye down your throat and just look for that coming out inside. And now if it comes out inside, they will stitch everything up and make sure there's no more leaks. And then once they're happy with it, they will let the gas out. They'll stitch you up, and then you go back to recovery. Have a good night's sleep, and then hopefully the next day you'll be making your way home. Can you guys see the green lines on the screen?
Yeah, not really. Yeah, not really sure why.
What's that happen? How's that happen?
It did it when Professor Sanapati presented as well.
Did it?
Yeah.
So it's not just me.
No.
There's several operations that we offer at Salford. Gastric banding is the first one that we'll talk about, then sleeve gastrectomy, and then the two different types of bypasses. So we'll run through them quickly. So the first operation, the gastric band, it's not done as much anymore. As we'll see why shortly. But basically, this is the band here, and it's wrapped around the top of the stomach, just below where the esophagus meets the stomach. So it's a small pouch at the top there. And we can inject the port that's just under the skin there with saline. The saline travels all the way up here and into here, and these balloons on the inside of the band fill with fluid, and it gets tighter around your stomach. So it works by restricting the amount of food that you eat. So as that band gets tighter, you eat less, basically. It promotes satiety after a small amount of food. But the risks are that the band can erode and it can leak. And there's leaks from like the reservoir here, or the tubing can disconnect, or the band can move and it can tilt in different directions. So we actually find in the NHS that we take out more bands than we put in, because there's more complications with them, unfortunately. Other downsides is that 10% of people fail to achieve much weight loss, and some people do regain weight in the long run. Now that's the possibility for the sleeve and the bypass as well, but more people we tend to find put weight back on after a gastric band. There's little restriction to sweets, chocolate or alcohol. They slip through nice and easy. You don't get very much restriction with them, so you can that's why a lot of people fail to lose much weight. In terms of excess weight loss, we always say it's about 50% excess weight loss in 2 years, 2 to 5 years really. So if you were 10 stone overweight, you'd be looking to lose around 5 stone in the first 2 to 5 years. So it's not as quick as something like the sleeve or the bypass. But there's no cutting or stapling of the stomach, and it's obviously adjustable. So if you've got a target that you want to achieve and then you want to stay there, you can actually adjust the band, take the fluid out, leave it in, and then you'll be back to normal portions, and that will be absolutely fine. So obviously there's some good things about the gastric band, but obviously some bad things as well. Okay. Next operation is the sleeve gastrectomy. So the sleeve used to be the first part in a 2-stage procedure, but now it's gaining more and more popularity by itself. And what we know, they use kind of a stapling device that cuts and staples at the same time. It's quite a funky little machine. So they start at the bottom of your stomach, a few centimeters away from the bottom of your stomach, that valve there, and then they cut and staple all the way up here. So there's a line of titanium staples there in the stomach that are left there. They don't degrade. They are left in there permanently. They don't get removed. They're absolutely fine for MRI scans and going on flights and things like that. So it's completely safe to do that. And this bit of the stomach here is actually removed. It's physically taken away. It's sent for histology, and you never see it again. But obviously, once that's gone, it's not going back. So there's no kind of reversal of this procedure. Once it's done, it's done. So you've got about, kind of 1/3 to 2/3 of your stomach left. So it's really kind of small portions. You're not going to be feeling as hungry, and you're also full quickly because the small stomach size. And there's a hormone that's produced in this bit of your stomach called ghrelin, and then ghrelin makes you feel full. So if you've not got this bit of the stomach there, you don't get as much ghrelin produced, so you don't feel as hungry. So it works in 2 ways: small portions because you can't fit much in that sleeve, and also reduced hunger because you've gotten less ghrelin. So in terms of weight loss, we always say around 70 to 75% of your body weight will be gone in the first 12 to 18 months. So if you're that person that's 10 stone overweight, you're looking at 7 to 7.5 stone within that first 12 to 18 months. So as you can see from a band, at 50% at 2 to 5 years, the sleeve is a little bit quicker. Downsides to the sleeve, obviously it's not reversible, and it could create reflux. Because you've still got the sphincter at the bottom of your stomach here, it can actually create a positive pressure, and it can push acid back up here. So if you've already got gastric reflux, maybe this isn't the best operation for you, but then again, it might be. It might just be that you need to speak to the surgeon, and between you, you'll work out which operation is best. It's a quicker operation than the bypass. So if somebody, we want them to be on the table a little bit less time, but we want to do a primary procedure like this, then the sleeve might be the one to go for. A sleeve probably would take about 60 minutes to 90 minutes, something like that, depending on the patient and the surgeon, how many coffees he's had that day. So yeah, it's quite a quick procedure. There's this thing called dumping syndrome, which we'll talk about in a little while, but occasionally the sleeve causes dumping syndrome, but not very often. It's more the gastric bypass, which is this next operation, that causes dumping syndrome. So this is a little bit more of an intricate operation, a bit more to it, and that's why it takes a little bit longer. It takes maybe 90 minutes to 2 hours or something around about there. And the first part of the operation is to make this small pouch here. So they use that same stapling device to staple off this bit of the stomach at the top, and they leave that pouch where it is. They then divide your small bowel in 2 down here, and they bring the lower half up to your stomach, and they join them together. So there's a hole between that stomach pouch and the bit of your small bowel, and there's also a join between these bits of bowel down here. So your food now goes down your esophagus and into your little small pouch, down into your small bowel and down here to be digested. So your stomach and your small bowel is left intact, still has a blood supply, and it will let you know it's there. It does growl occasionally and lets you know, that it is still there. But it is bypassed, so no food goes down here. All the acids that are produced here and the enzymes that come in here are introduced via this join. So your food is digested and absorbed as normal down this way. As you can see, with this being still in situ, you can actually reverse this procedure, but it's a major operation to do that, and we would only do that in cases where you're failing nutritionally for whatever reason, or you become poorly for other reasons, and that's needed. So it can be reversed, but we don't do that. We don't do that very often, but just in kind of the severe cases. But it has been done. A different type of a different type of gastric bypass is a single anastomosis. So this one has two anastomoses. Anastomosis is what we call a join, basically. So there's a join here and there's a join here. So two anastomosis in the Roux-en-Y. Whereas a single anastomosis, there's just one join, just there. So what they do, they make the pouch a little bit longer, and then they just bring a loop of bowel up and they attach it to the bottom of the pouch. So there's no cutting or stapling, well, there's no cutting of your small bowel. They just bring a loop of it up here and they attach at the bottom. So your food now goes down your esophagus, into your stomach pouch, and then down into your small bowel to be digested, bypassing this section of the stomach here and this section of the small intestine, just like the Roux-en-Y bypass did. So it works in much the same way, but there's only one join. So the surgeons might do this operation in patients that maybe are a little bit bigger and there's more pressure kind of in the abdominal cavity, so they only want the risk of one join leaking rather than the two. And they might do this one if they want a shorter operation. They want to do the bypass, but they want a shorter operation, so they might do this one instead, because there's less work to do. There's only one join to make rather than two, so it's a quicker operation. I hope I've explained that okay and everybody understands. So the bypass works by restricting your portion size. Basically, you've got a very small stomach pouch. You can't fit much food in there, so you feel full really, really quickly. And it does produce influences those hunger hormones. So the ghrelin, the same one, the sleeve kind of reduced, does the same thing. But there's also another hormone that acts as kind of a brake mechanism. So when your food gets down here normally, it signals your body to tell you to stop eating because you've had enough. So normally your stomach's full and there's food coming down here. So it says, I've had enough, stop eating. So it releases this hormone, makes you feel full very quickly. But obviously after a bypass, that hormone is being produced straight away. As soon as the food gets into that bit of the intestine, it's saying, I'm full, I've had enough, stop eating. So you've got a small portion size, you're less hungry because of the less ghrelin, and you're full quickly because of that hormone that's produced down here. And it also works with dumping syndrome. And we'll talk, there's a slide on that in a little while, we'll talk about that in a bit more detail. And on average, people lose 75 to 80% of their excess weight in the first 12 to 18 months. So if you were that 10 stone overweight person in the first year, you'd lose 7.5 to 8 stone on average. So the bypass weight loss is a little bit better than the sleeve, but not so much. I've had people with a sleeve that have lost far more weight than a bypass patient, and bypass patients that have lost less. And so everybody's very, very different, and it's how you work with the operation to get the most out of it. So obviously the excess weight loss is very good, and the remission of diabetes and sleep apnea is kind of instant. We see people that come into hospital on one day, they have their operation, on the next day they're off all their diabetes medications and it's in remission. We don't say cured because you've still got to go and have your eyes and your feet checked, but we do say it's in remission. And sleep apnea as well, that can be resolved overnight, even though you've still got the same amount of weight around your neck and around your lungs. The sleep apnea can improve overnight too, and you can actually come off your CPAP machine in some cases, but you keep under regular review with the respiratory team. Unfortunately, it is a longer operation because there is more to do, and there's higher chance of leaks and higher risk of internal hernias because they've done more jigging around with your small bowel, and there's more kind of staple lines. It's higher risks of leaks as well. And then dumping syndrome. So we're going to go on to dumping syndrome. So this is a syndrome is kind of a collection of symptoms, and you can have one or two of the symptoms, or all of them if you're unfortunate. So the symptoms can include faintness, sweating, palpitations, nausea, vomiting. Basically, you just don't feel very well. You can end up being sick. You can end up having a bit of diarrhea. You feel a bit faint, a bit sweaty, a bit shaky, that type of thing. And it's caused, if it's early dumping syndrome, it's caused within 15 to 20 minutes of having something to eat. And it's normally when you have something that's a bit too high in fat or a bit too high in sugar, or you've not chewed something particularly well and it's giving you a bit of grief. So basically what your body does is tries to get rid of it, and it shoves a load of fluid into your gut to dilute it. And that reduces your blood pressure a little bit, makes you feel a little bit unwell. So that's what's happening. If it's happening a couple of hours after your meal, it could be due to a reactive hypoglycemia. So your blood sugars have gone up really quickly, and then they've come crashing back down a couple of hours later because the food's been absorbed very quickly. The blood sugars have gone up very quickly, and then they come crashing back down just as quick, and it leaves you feeling very, very unwell. So that's dumping syndrome. So not very pleasant, if I'm honest. A lot of people say they just want to lie down for half an hour and they feel fine. But obviously it's not something that you want to be doing if you're out and about. And unfortunately, some people do get dumping syndrome so severe that they have it after pretty much every meal. And unfortunately, some people don't get dumping syndrome at all. So if you're a person that really likes sweets and chocolates and you want a bypass because it's going to give you dumping syndrome, unfortunately, you can't guarantee that it will. It might do, and you can hope, but we can't guarantee that it will. So hopefully, bit of a brief overview of all the surgeries. I hope that was okay. And then we're going to go on to onto the dietary changes. So you're all with a weight management program, whether that's with the guys that choose to change, whether it's at More Life or with guys at Bolton or with us in Salford, and you're all trying to achieve a little bit of weight loss, going through this education program in view to getting your bariatric surgery. So we do want you to be as light as possible for the operation, and I know that's why you're in these groups, to try and lose a little bit of weight. But the lighter you are, the safer the operation is. So anything that you can do to lose weight until that operation will be really beneficial. It makes it easier for the surgeon. Basically, it makes Prof. Senapati's life a lot easier if there's a lot less weight around your stomach, because the instruments move around a bit easier. There's less weight in your liver, so they have to move that out of the way less. So it just makes their life easier. So if it's easier for them, it's safer for you. So that's the benefit of trying to lose weight within these weight management groups. So what we want you to be doing is making sure that you're preparing yourself for surgery. So trying to get into the habit of eating regularly, following the rule of 20 and trying that as homework, and we'll go through that in a little bit, separating your eating and drinking and things like that, and getting on with trying to get some weight off before surgery. So when you come and see us in clinic, we will go through all this kind of information again. We'll make sure you know what you're getting yourself in for and what you're doing. And then 2 weeks prior to your operation, you start this liver reduction diet. And now this is necessary to make the operation, again, a little bit safer for you. So it helps to reduce your weight, but it also reduces your liver size. So your liver is this big organ here, and it sits across your stomach. And you can see the stomach just behind it. And that's where they do the majority of the work, in that top area. And the liver covers it up. So we know that if you follow a low carbohydrate diet, low calorie carbohydrate diet, your liver shrinks, and it's always this left lobe of the liver that moves out of the way. So it actually just shifts over a little bit, so the surgeon can get in there and see a little bit easier. So if it's easier for him, it's safer for you. So 2 weeks prior to the operation, unless you're told to do more by the surgeon, so he might ask you to do a little bit more than that. He might ask you to do 4 weeks, and occasionally they might ask you to lose a little bit more weight, in which case they will ask me to be involved with you regularly before your operation to try and get you at a weight that the surgeons are happy to operate safely. Try not do, well, you can't follow this after the operation, it's not suitable. So it's just 2 weeks prior to the operation. And if you have any problems with your kidneys, where your fruit and vegetable and your fluid intake is limited, then please speak to me before the operation, and we can try and get you an alternative to follow. And if you have diabetes as well, please do also speak to me, or speak to your diabetes provider with a copy of the liver reduction diet, and tell them what you're going to be doing, so they may need to adjust your medications. Only really for people that are taking things like glycoside and insulin, not really for people that are taking metformin. You can still carry on taking that with this kind of diet, and you will be absolutely fine. So the liver reduction diet that we ask people to follow is based on food. There are alternatives around. There's milk and yogurt diet, or there's meal replacements and things like that, and they're absolutely fine. You can have those if you like, but the one that we ask you to follow is based on food, and I like it because it gets you into good habits, and it's also good for your bowels. After the operation, as you'll see in a second, that you're going to be on liquids for a little while and then on puree, so it tends to slow down your bowel habit a little bit. So eating solid foods beforehand is beneficial to keep your bowels moving, but also to get you into that regular eating pattern. So as you can see, you're allowed 1 portion of carbohydrate 3 times per day. And notice I didn't say you can save up that 3 portions of carbohydrate for 1 meal. I want you to spread them out through the day. On top of that, you're allowed 2 portions of protein. So your protein is your meat, fish, eggs, things like that, and 2 portions of dairy. So a portion of dairy is like a small yogurt pot, or a third of a pint of milk, or something like that. And then 2 portions of fruit on top of that, with then unlimited non-starchy vegetables and salad. So there's 5 vegetables that you need to avoid, and they're peas, sweet corn, beetroot, squash, and parsnip. All the other vegetables you can eat unlimited amounts of. Obviously, if you have other conditions that restrict your fruit and vegetable intake, or your vegetable and salad intake, you need to let me know, and we can come up with an alternative. So in the information that we give you that's available on our support group website, if you've had a look at that, it gives you what 1 portion of each of these different food groups is. So then you can mix and match the different portions of carbohydrate, of protein, of dairy and fruit throughout the day, and you can make a plan that fits in with your normal routine and that of your family as well. So there's an example meal plan of what you might have there. So you can see the portion sizes of carbohydrate foods are very small. 3 tablespoons of cereal is 1 portion. 1 slice of bread is 1 portion. 2 tablespoons of cooked rice or pasta is 1 portion. So you can see how restrictive the carbohydrate portions are. On top of that, you're allowed a small piece of meat or fish or pulses, or whatever in terms of protein, and then we've used lots of vegetables or salad to make sure that you're feeling really, really full with your meals. You can have your fruit and yogurt as snacks in between, and then drinking plenty of water. So drinking plenty of water or no calorie fluids is really important to stay hydrated. So do drink plenty and make sure you're feeling full as well. Just trying to think if there's anything else that I've missed. Yeah, well, you are going to be feeling pretty hungry on this diet to start with. The first kind of 3 to 5 days is the hardest. After that, it tends to get a bit easier. But the people that are most successful with this diet plan really utilize the unlimited vegetables and salad really, really well. So they'll make themselves a side salad when they have, the 1 slice of bread and a bit of meat as a sandwich. They'll have a big side salad. They don't put any dressings on it, and you feel full that way. So just make sure that you utilize those unlimited vegetables and salad. After the operation, we put you on this very strict recovery diet. So it's liquids and then puree and then soft for 2 to 3 weeks each, depending on the operation and depending on yourself, really. This very much is just a guide. I don't want you to be rushing through the stages. If you're struggling with liquids, you stay on them a little bit longer, but if you're ready, within that 2 to 3 weeks, you can start to move on to a little bit of really loose puree, and that's absolutely fine, as long as you're kind of sticking to the rules and you're not being sick and having no problems, then that's okay. Other places might say something different. So some places put patients straight onto a puree diet, but we don't. We ask you to follow liquids. And we know that it doesn't cause many problems in our patients. So we want you to follow what we say. Um, and the aim is to get you back to normal foods in a structured way without making you sick. So you're introducing foods that are nice and light, so all the liquid foods that don't need chewing, and they go through the operation quite easily. So that just allows everything to heal up. And then gradually you introduce more and more texture to get used to it in a way that's not going to make you sick. And then hopefully and eventually we get you back to normal foods, and you'll be eating small portions of normal foods within kind of 9 to 12 weeks. Like I said, I don't want you to be rushing the stages. You've had a major operation. Your body's going to have to get used to it, really. And things like taste changes are quite common. So any operation on your stomach or on your esophagus can affect your taste buds. So kind of be prepared to find things that you liked before that you don't now, and vice versa. So a common one is things like tea and coffee. A lot of people come back after their operation and say, you know, I don't like coffee anymore. What else can I have? And it's all just about finding out what you do like now rather than what you liked before. And really use it as an opportunity to change your relationship with food. Get into the habit of eating regularly, of planning ahead, taking small portions of food. The operations are there to help you lose weight. They'll help you control your portion sizes, but they won't do it by themselves. If you're somebody that eats for comfort or that eats out of boredom, try and get out of that habit with the help of the operation. The operation is not going to do that for you, but it will help you to do that by a portion restriction and control with your hunger as well. And you've got myself and Jodie for 2 years afterwards to help, and also our psychologist Julia can also help with that as well. So more about the liquids. So after the operation, you're given like a little tiny medicine cup full of water, and you've got to sip that nice and slowly. Take your time with it. Don't rush. Don't neck it back all at once, and don't gulp. And then when the nursing staff and the surgeons are happy, they'll give you a glass and a jug, and you can drink freely. Day after, they'll give you some clear soup, some consomme, and tea and coffee, things like that. But then when you get home, you're on a free fluid diet. And what I mean by that is any fluid that you can pass through a sieve and that you can suck through a straw. It's got to be low in fat and sugar and not fizzy. And you've also got to avoid alcohol for 6 months after the operation. So you're talking, you know, soups and smoothies, milky drinks, anything like tea and coffee or water, no added sugar, squash, all those types of things are absolutely fine. And also, like I said, avoid alcohol. So make sure that you're taking small, frequent sips, and make sure that your urine output is nice and clear. So when you go to the toilet, have a look and make sure it's clear. If it's dark, you need to be drinking more. And that going back to the alcohol point, make sure that you're avoiding alcohol. If you do get a little bit tipsy, because people do get tipsy a little bit quicker after the operation, you become a bit of a cheap date. So, you know, half a glass of wine or whatever it is that you drink, and you'll be maybe on the floor. So introduce alcohol in a safe environment when it's safe to do so, because if you do it too soon, you might do things that you shouldn't do with food. Go and get a kebab or a pizza or something like that and end up hurting yourself. So we don't want you to do that. So make sure that alcohol is the last thing that you introduce. So in terms of when you're on the liquid diet, we want you to be following a nourishing liquid diet. So having plenty of protein in there to help heal up. And women need about 60 grams per day, men need about 80 grams a day. So what we ask you to do is aim for a pint of milk every day and to put some skim milk powder into there. So Marvel is the common brand name, but supermarkets do their own varieties, and that's just as good. Then you put 4 tablespoons into 1 pint of milk, and then you mix that up and drink it through the day. That 1 pint of milk will then give you 40 grams of protein. So for guys, it's about half of what you need, and for women, it's about 2/3 of what you need. So it's a really good start to the day to make sure that you know that you're getting everything that you should be. And also include things like blended high protein soup, so anything with meat or pulses, anything like that in there. You can even add some skim milk powder into your soup to give it a little bit more protein as well. You can use protein shakes if you want to, but I'd probably just discuss that with me first and make sure that there's no kind of nasties in there that you don't need. But if it's just a plain whey protein, that it should be absolutely fine. Just trying to avoid anything that's got any added sugar or anything else in it. And what we ask you to be doing with that liquid diet is having a nourishing drink every 3 or 4 hours. So a nourishing drink in my eyes is anything with protein in it. So whether it's a soup or a milky drink, a smoothie, a diluted yogurt, something like that, every couple of hours. So for example, for breakfast, you might have a milky coffee. Mid-morning, you might have a diluted yogurt. Lunchtime and evening meal, a different type of soup, so you don't get bored. Mid-afternoon, maybe a yogurt drink again, and then before bed, a decaf milky coffee, like a decaf latte or something like that. So you've got that regular intake of high protein fluids through the day, and then lots of water, no added sugar, squash, tea and coffee, like things like that, throughout the day. The next stage is the puree diet, and this is the bit where you start to reintroduce food without vomiting. So the consistency should be like applesauce, so really soft and smooth, and it should just drop off a spoon. We do want you to be introducing high protein foods first to facilitate that wound healing, so that focusing on those foods is really important. So use plenty of sauces and gravy and milk and things like that to make sure that everything's nice and soft and blended down. If you do make yourself kind of a Sunday dinner and just scrape it into a blender and hit go, it does turn a little bit grey and mushy and smelly. So separating out your food and blending it separately is a good idea. It makes it look a little bit more appetizing and appealing. But things like curries, bolognese, shepherd's pies, things like that, all blend down really, really well if you put a little bit of extra sauce or a little, another tin of tomatoes in there, a little bit of milk, anything like that. Blend it down really well. And a lot of people will cook in bulk, so they'll make themselves, for example, one chili or something like that. Low-fat chili, plenty of tomatoes in there, blend it up really well, and then portion it out into little kind of containers that you can put in the freezer. And that one dish, if you make three dishes that are similar, that will probably do you for the full 3 weeks, because you're only going to be eating very small amounts. So in terms of eating pattern, I want you to be sticking to the same eating pattern that you were doing on the liquids. Eating a nourishing meal or snack every 3 or 4 hours, but it doesn't have to be puree. It can still be a liquid, so you can still have a milky drink if you want to. You can still have you can have a soup at lunchtime. If you're back at work, for example, you don't want your colleagues seeing you eating puree, you can have some soup, and that's absolutely fine. As long as you're eating some puree to get used to it, I'm fine with that. Eating habits are really important, so it's not just about what you eat, it's about how you eat it as well. And on the puree, that's really important to get used to, because you've got this kind of mashed potato consistency stuff, and that you're going to put it in your mouth. And normally, you wouldn't probably need to chew that very much. But after the operation, if you put a spoonful of mashed potato in your mouth and swallow it without chewing, you're going to end up in pain, you end up being sick. So it's really important that you just take the tip of a teaspoon at a time, so just the very edge of a teaspoon, a small amount in your mouth, and chew it really well, and let it go down and let it settle. And if you're not feeling sick or you're not being sick, you can have another little bit. So those eating habits you need to be kind of mindful of and carrying on for in the long term. Do need to have a rest in between each bite and separate your eating and drinking as well. So 15 minutes before your meal, you need to stop drinking. Half an hour after your meal, you can start to drink again. And that's really important to make sure that you're not being sick, for one, because your stomach just can't hold the volume, but also to make sure that you've got a decent amount of nourishment going in, so you can fill yourself up with food rather than fluid. So an example meal plan on the screen there, so you can see again, regular eating throughout the day, small portions, and there are obviously some liquids in there as well, so you can introduce those. So soft diet, and this is the bit where you start to introduce normal textures, but gradually. So you've done liquids, then you've done the puree, and now you're onto soft. So if you think about it like fruit, you've gone from fruit juice to fruit smoothies to fruit puree, and now you're going to introduce some mashed banana, and then you're going to introduce some peaches out of a tin that have been mashed up, and then gradually more and more texture, so having an apple that's been peeled and then having an apple that's not been peeled, and then you're back to normal food. And if you think about it in that way, I want you to do that with the rest of your food as well. So really easy stuff to start with, and then gradually moving through the consistencies back to normal foods. And obviously everybody's different in what they can and can't tolerate. So everybody's very individual. A lot of people do have some food tolerances. quite common. So things like red meat, white meat, fish, bread, pasta and rice and stringy vegetables are all very common food intolerances. They just don't seem to go down very well. But if you're chewing everything really well, you should be able to manage a wide variety in your diet. So that sums up the kind of recovery period. And then going on to some long-term dietary changes to kind of keep the weight off, really. And note at the bottom there, not following these habits can lead to poor food tolerance and weight regain. So all these things that are on here are there to make sure that you're eating enough of the right things, not being sick, and also preventing weight regain in the future. So one of the habits that we ask people to get into is called the rule of 20. So the rule of 20, if you've not heard of it, is nothing in your mouth bigger than a 20p piece. So you've got to get a 20p piece out of your pocket, put it next to you when you're eating, and cut food up that small. You've then got to chew that food 20 times. So you've got to get into the habit of chewing it and counting at the same time. Put your knife and fork down for 20 seconds and then stop eating after 20 minutes. So it's small bites, chewed thoroughly, taking your time and stopping after 20 minutes. If you're eating any longer than that, you don't need it. You've kind of reached that point of fullness. We want you to be eating 3 meals a day. So aim for that 3 meals a day pattern. You can have a snack in between if you want, but the majority of people by kind of week 12 can only manage 3 small meals per day and then lots of fluid in between, and that's absolutely fine. We want you to be separating your eating and drinking like we talked about previously. So 15 minutes before, half an hour afterwards to make sure you get enough nutrition, and avoiding fizzy drinks because they can actually stretch your pouch, and we don't want you to be having too many fizzy drinks because obviously some of them can be quite sugary. And we want you to avoid what we call slider foods. So slider foods go through the operation quite quickly, and you can eat them in large portions. So even if you're doing that rule of 20, you can eat more of it because they're softer, they go down easier, you don't need to chew as much, so you end up eating more of them. And another point to make is that I don't want you to be returning to meals after you're feeling full. So if you've got, a small portion of food, so you've got your tea plate portion, that's how much you're going to be able to manage, and you only manage half of it, I want you to stop, and I want you to either throw it away or save it for the next meal. Don't go back to it in half an hour and finish it. Because if that happens then, 12 months down the line, your portion size might have gone up a little bit. And if you do the same thing again, your intake has increased. And if that goes on, you can actually go back to having the same portions as previous. So try not to return to meals after feeling full. And avoid grazing. So this 3 meals a day pattern is really important to get that regular eating pattern. You can have a snack in between, that's fine, as long as it's a defined snack and it's in with your plan. So a piece of fruit or a yogurt or some nuts or a cereal bar, something along those lines. If you graze, what I mean by that is just picking at food. So even if it's a punnet of grapes or a punnet of strawberries, something like that, if you finish that over the day just by picking at them, that is what we call grazing, and that is the biggest predictor of somebody that's going to gain weight, is grazing. So 3 meals per day, a small snack in between is fine, but nibbling on food throughout the day is a no-go because that will probably lead to weight gain. Avoid foods high in fat and sugar, obviously, and include 1 portion of protein at each mealtime. Check your food labels, make sure everything's low in fat and sugar, and that's just a recap of the rule of 20. So make sure that you're practicing this. So I don't know if you've got the opportunity to take a picture of the screen or write it down, because I do want you to practice that. It's really quite difficult to do. It's a necessity when you've had the operation to make sure that you're eating enough and the right things, but making sure that you're chewing everything really well is really important. And it will help you with getting some weight off before the operation, because by the time you've finished this, your food is pretty cold. And not a lot of people like cold foods, and you're going to be quite full as well, and you're going to be bored of chewing. So do practice. So fluids after surgery, again, avoid alcohol and fizzy drinks. I think I've said that a few times now, so important that you do. Limit your fruit juice and your milk intake and drink plenty of water. No added sugar, squash, tea, coffee, etc. And make sure that you're drinking plenty, keeping your urine output nice and clear. Portion sizes are a really important topic. So the idea is that to start with, you're going to be on really tiny portions. If you said to me that you were having Weetabix for breakfast in the first kind of 3 to 6 weeks, you're probably managing a quarter to a half of a Weetabix. 2 years down the line, you could probably manage 2 Weetabix without a problem. And if that's the case, then you need to be looking at texture, because Weetabix is quite soft. We still want you to be having a side plate full of food. So if you've got a large plate and it's full of soft stuff, we want you to be eating lots more texture to get that portion size down again. And hopefully they will stay that way. But be realistic with your portion size. Don't kind of start using bigger plates, because if you get bigger plates, you naturally fill them with more food. And that one forkful too much repeatedly will lead to your stomach pouch stretching, and then you putting weight back on in the future. And obviously that's not what we want. So portion size need to stay the same, otherwise you might regain weight in the future. And planning ahead, really, really important after surgery. It helps you focus on the changes that you need to make, and it reduces the chances of you kind of lapsing and going for things that you shouldn't do. So make sure that you do plan your meals and snacks, and start with the recovery diet. You know, it's going to be something completely new. You're going to be on liquids for a little while, then puree for a little while. So these are foods that are going to need a little bit more time to prepare and store and heat up and things like that. So you're going to have to get into that habit of planning ahead, and I'd like you to carry that on in the future for when you're back to normal foods. So just to talk about a couple of the complications of surgery that are related to nutrition or eating habits, really. So all the ones on your slide there can be related to your nutrition, apart from these two: excess skin and addictive behaviors. So things like nausea and vomiting are generally to do with your eating habits. If you're not following the rule of 20, you can get nausea and vomiting. So make sure that you're going back to your eating habits. And if you're still feeling sick or being sick, then you need to let us know, and we can investigate. Diarrhea can be caused by a couple of reasons, and so can constipation. But if you're having ongoing problems with these two for more than 5 days, then you need to let us know. If you have diarrhea, it could be a result of dumping syndrome, but it also could be a result of having a high fat meal, because you can get some fat malabsorption. So being strict with your dietary choices is really important. Constipation, a lot of people suffer with constipation in the first kind of 6 weeks because you're not getting as much food and fluid in. Your bowels don't open as often, and that's really common. So what you can be doing is making sure that you have lots of fluid, so keep your fluid intake up, and introduce some fiber into your fluids as well. So vegetables in your soups and fruits in your smoothies blended up really well will help to get that fiber in, and help you with the constipation. Dumping syndrome we've already talked about, so make sure that your eating habits are good and everything's low in fat and sugar, and things like your fecal incontinence, impaction, abdominal pain. All these things can be caused by dietary inadequacies, low fluid intake, all that kind of stuff. And we have experienced some people with unexplained abdominal pain. Now, sometimes that can be caused by things like bacterial overgrowth, which can actually cause things like diarrhea and nausea and vomiting. So that's why, if these things are ongoing, you do need to be letting us know. So if you're having these problems for more than 5 days and you've looked at your diet, you can't find anything that's obvious, then give us a call and then we can help you with it. Things like your excess skin, that is not really to do with nutrition. Unfortunately, some people do think it is, but it's not. Unfortunately, some people are going to have excess skin. No matter how much you exercise, no matter how healthily you eat, no matter how much water you drink, some people are going to have excess skin. So I'd rather you go into the operation thinking that you are going to have excess skin rather than hoping that you won't. So I want you to get that straight in your mind, that after the operation, you are going to have excess skin. And then if you don't have it, it's a bonus. But the more than likely, you will have some excess skin, and it's how you're going to deal with that mentally after the operation. And addictive behaviors can transfer into alcohol and drugs. So if you're a food addict, that can transfer into drugs and alcohol, and that can be very, very detrimental, and we have seen that in the past, unfortunately. So if you do have an addiction to food and you don't think you could do without it, then you do need to highlight that with our psychology team, and they can help you through. And obviously malnutrition, obviously that's due to your nutritional intake. So if you follow all the advice that we say and you take all the supplements, this shouldn't be an issue. And we also kind of keep on top of you. We'll take your bloods at 4 months, and then at a year, and then annually for life, to make sure that you're not malnourished. And these are the supplements that we give you. So we give everybody that has a bypass or a sleeve, all the types of bypass, a complete multivitamin. We like the one called Forceval that you can get on prescription. Alternatives are things like Centrum Advance or Synatogen A to Z, Tesco's own brand Boots A to Z. As long as it's an A to Z multivitamin, that's fine, and you can take that one twice a day. Whereas the Forceval, we just like you to take that once a day. Calcium with vitamin D, we put everybody on calcium and vitamin D. It's normally a once daily tablet, and it's quite a nice flavoured chewable thing, and not many people have problems with that. Some people do have problems with the multivitamin. It's quite a big tablet. If you are having problems, then we can help you out with an alternative. Iron tablets, we put you on 2 of these a day for people that are menstruating still. For men and maybe older ladies, you only need to really take 1 a day, but we do keep an eye on that. And we know that iron causes constipation as well, so we do quite often tinker with the iron supplements after surgery, especially in the initial stages. And then everybody has vitamin B12 injections. We ask the GP to prescribe that every 3 months for life. So if your GP ever takes you off any of these supplements, make sure they are taking your bloods regularly, so every 6 months or then annually. And if you're deficient in any of them, they should be starting them again. One thing to note at the bottom here is to not take them together. Don't take your iron and calcium together, because they affect the absorption sites, but I don't expect you to remember that right now. It's just something that was on the slide already. Thank you. So I hope I've given some insight into the different operations, the types of surgery, the benefits, the pros, the cons, and the risks, and also the dietary changes that you're going to need to make before and afterwards as well.